Hi there, my name is Joan and I'm an instructor with the ACCN program. This presentation is part 2 of 3 review presentations for Module 5. In this presentation we will focus on the autonomic nervous system and adrenergic receptors. The human nervous system consists of the central nervous system, the brain and spinal cord, and the peripheral nervous system, which is further divided into the somatic and autonomic nervous system. Our area of interest is the autonomic nervous system, which contains the parasympathetic nervous system and the sympathetic nervous system. We will further focus our discussion onto the sympathetic nervous system. As mentioned previously, the sympathetic nervous system does its work through catecholamines, which stimulate alpha and beta receptors throughout the body. The sympathetic nervous system helps mobilize the body and prepare it for responding to a threat. It is stimulated by emotional stress such as fear and anger, as well as physical stress such as injury or shock. This is primarily facilitated by the stimulation of alpha and beta receptors localized strategically around the body. This figure illustrates some of the areas stimulated, such as blood vessels, adrenal glands, and the heart. We'll take some time now to go into the location of and response to stimulation of those receptors. There are 3 classifications of receptors in the sympathetic nervous system, and they're categorized based on the location and response to stimulation. First, there's alpha-1 receptors, which are found predominantly in the peripheral arteries and veins and cause vasoconstriction. Beta receptors, which we'll break down further into beta-1 and beta-2. Beta-1 are found in the cardiac tissue and increase heart rate, AV conduction, and contractility. Beta-2 are found in the lungs, causing bronchodilation, and in the peripheral arteries and veins, causing vasodilation. The third type of receptor is the dopaminergic receptor and is located in the renal, mesenteric, and vascular beds and cause vasodilation, as well as have a direct effect on the kidneys, inhibiting sodium reuptake. We will be discussing each of these receptors in more detail in the slides to come. Adrenergic receptors respond to sympathomimetics differently depending on modifications in their primary structure. For example, epinephrine has more beta-1 stimulating properties than norepinephrine. This is something we can exploit in critical care depending on the specific situation. For example, if our goal is to improve systemic vascular resistance, but not increase the stimulation of the heart, norepinephrine would be a better choice. These receptors exert their effect via stimulation of G proteins, which either stimulate or inhibit cellular responses in target cells. Pictured here is a diagram of an alpha receptor. Once the agonist attaches to the receptor, the G protein is stimulated and energy is released via ATP. This in turn stimulates isotyl triphosphate, or IP3, causing the release of calcium from the endoplasmic reticulum, causing contraction. Remembering that alpha-1 receptors are found in the peripheral arteries, the consequence of this contraction is vasoconstriction. The potency or affinity of alpha-1 receptors to sympathomimetics is as follows. Epinephrine has a greater or to equal effect with alpha receptors as norepinephrine, which has a significantly greater effect than isoproterenol. The strongest affinity for alpha-1 receptors is phenylephrine, which is considered a pure alpha agonist, whereas the strongest affinity for alpha-2 receptors, which we'll discuss momentarily, is clonidine. Alpha receptors have been divided into 2 subtypes, alpha-1 and alpha-2. Alpha-1 receptors are located postsynaptically in the smooth muscle of the blood vessels, as well as the genitourinary tract, the gastrointestinal tract, the heart, and the liver. As previously mentioned, the main response to alpha stimulation is arterial and venous constriction. Alpha receptors found in the heart have minimal effects on contractility. In general, alpha-1 agonisms are used for their cardiovascular effects, specifically vasoconstriction, but there are other effects as seen in the GI and GU system, the liver, and the eyes. These are mydriasis, so dilation of the pupils, relaxation of the GI tract, GU smooth muscle contraction, and within the liver they can cause glycogenolysis and gluconeogenesis. In contrast, alpha-2 receptors are located presynaptically within the brainstem and in the smooth vascular muscle. The response to alpha-2 receptor stimulation is also very different from the alpha-1 receptor stimulation. Instead of vasoconstriction, we actually see vasodilation. Other effects of alpha-2 stimulation include platelet aggregation, decreased release of norepinephrine, and inhibition of sympathetic flow. For the purposes of this review and the information you'll be learning about in Module 5, alpha-1 receptor activation is the most important. Alpha-1 receptor activation predominantly causes vasoconstriction. When we review the determinants of cardiac output, the main response of alpha-1 receptor stimulation is an increase in systemic vascular resistance or afterload. Stimulation of beta-1 receptor causes a cascade of events slightly different than that of the alpha-1 receptor stimulation. In this case, protein kinase C is stimulated, resulting in increased calcium release from the endoplasmic reticulum, causing contraction. Because these receptors live predominantly in the heart, the result of this is increased heart rate, increased AB conduction, and increased contractility. Stimulation of beta-2G protein has yet another outcome, starting with the stimulation of protein kinase A. The response to this is an increase in the reuptake of calcium from the endoplasmic reticulum, causing vasodilation. In this way, beta-2 receptor activation opposes alpha-1 receptor stimulation. As with alpha receptors, beta receptor affinity for certain agonists varies. In this case, isoproterenol has a higher affinity than epinephrine, which has a higher affinity than norepinephrine. With respect to beta receptor subtypes, beta-1 has equal affinity to epinephrine and norepinephrine, whereas beta-2 receptors have a high affinity for epinephrine as opposed to norepinephrine. As mentioned previously, beta-1 receptors are located predominantly in the heart, resulting in increased heart rate, conduction, and contractility. They also exist in the juxtaglomerular cells of the kidney, causing the release of renin. Beta-2 receptors are widely distributed throughout the body. There are beta-2 receptors found in the heart, but they have a much less effect on the heart rate and contractility than beta-1 receptors. Their predominant location in the smooth muscle of the vasculature and bronchial tissues causes vasodilation and bronchodilation respectively. Other effects include increased gluconeogenesis, which is the production of glucose from proteins and fats, and an increase in glucagon, and the inhibition of histamine release. Sympathetic stimulation also causes the stimulation of dopaminergic receptors, or D receptors. D receptors have two subtypes, D1 and D2. D1 receptors are primarily found in the smooth muscles of the vasculature in the brain, heart, mesentery, and kidneys, and stimulation of these receptors causes vasodilation. D2 receptors are found extensively within the brain and spinal cord. Stimulation of these receptors interferes with norepinephrine release. So primarily what we're seeing with the stimulation of D1 receptors is vasodilation of the mesenteric and renal vascular beds, as well as inhibition of sodium reuptake. Whereas with the dopamine 2 receptors, we're seeing an inhibition of norepinephrine release. This concludes the second review presentation on the autonomic nervous system and adrenergic receptors. If you have any questions, please contact your instructor.